Hello, everyone. Today, we're going to be talking about anxiety, OCD, trauma, and stress-related disorders. So anxiety is one of the most common human emotions. It consists on a continuum from no anxiety or absence of anxiety at one end and a pathological level that produces significant symptoms of psychiatric disorder on the other. Anxiety can be normal, a healthy reaction to life stressors, and motivates a person to deal with events and emotions. Anxiety can be pathological if it is disproportionate to events, it is sustained over a significant time frame, and it significantly impairs the function of that person's life. Or if it's apparently unrelated to any identifiable event or situation, and high pathological levels of anxiety interfere with perceptions, memory, judgment, and motor responses. There are cultural differences that can affect behavioral manifestations of anxiety. For example, in Latin cultures, there's something called ataques de nervios, I'm not sure how you say it, which usually is a provoked disturbance in family bonds and may be manifested by trembling, crying, and screaming, but it's really a cultural component. And something called Kyle attacks are common manifestations among Cambodian and other Asian cultures and commonly manifest in neck soreness and tinnitus. So when we look at anxiety disorders versus obsessive compulsive and related disorders versus trauma, there are all of these different disorders. So within anxiety disorders, we have panic disorders, agoraphobia, specific phobia, social anxiety, selective mutism, and generalized anxiety disorder. When we talk about obsessive compulsive and related disorders, we have OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling disorder, where they actually pull the hair out of their scalp, excoriation, which is a skin picking disorder, and substance or medication-induced OCD symptoms. And then within trauma disorders, we have reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, dissociative identity disorder, dissociative amnesia, and depersonalization or derelation disorder. So when it comes to anxiety disorders, when we look at how we differentiate between all of those different types of anxiety disorders, this is a good algorithm. I love algorithms. So if we know that there's anxiety present, and if it is due to a medical condition, then we have anxiety disorder due to a general medical condition. If we have an anxiety disorder with an onset within 1 month of substance withdrawal, intoxication, or indigestion, it's substance-induced anxiety disorder. If symptoms are within 3 months of a stressor, it is an adjustment disorder with anxious mood. If there's a trauma exposure plus re-experiencing, avoiding, and arousal symptoms, depending on the timeline, which is listed there, it can be acute stress disorder or PTSD. Fear of a social situation, we have social anxiety disorder. Recurrent unexplained panic attacks would be panic disorder. Time-consuming or interfering obsessions or compulsions would be OCD. Excessive worry that can't be controlled would be generalized anxiety disorder. And anxiety or phobia symptoms that do not meet the criteria can be anxiety disorder not otherwise specified. So drugs that are associated with anxiety symptoms, there's a bunch of them here. I'm not going to list them all, but just to note that sometimes anxiety disorders can be caused by medications. A big one is corticosteroids. A lot of times people start prednisone and they have a big increase in anxiety. That can happen. So anxiety disorders. So there's different levels of anxiety, right? Mild, moderate, severe, and then full panic. And this just kind of breaks it down of what that could look like. So like mild anxiety is a normal level, which actually helps to motivate people. Having like mild anxiety when you're taking an exam is actually really good because it's going to help you to focus and have like heightened awareness. When you start to have moderate levels of anxiety, this is, your vital signs are still normal. You might have a little increased heart rate, some moderate increases in muscle tone, and you might have start to be feeling like tension or worried. But then you start to get into like a severe level of anxiety. This is when your autonomic nervous system has been activated. You're in that fight or flight. You're going to have like, sweating, muscle rigidity, hearing decreases, perceptual field greatly narrows, difficulty with problem solving. So like taking an exam and having severe exam anxiety, that can impede your ability to do the exam because you're having difficulty with problem solving at that level. And then when you're in full-blown panic, you're pale, hypotensive, poor eye contact and coordination, decreased hearing, dizziness, shortness of breath, illogical thinking. So that is obviously not good. So anxiety disorder theories, there is the psychodynamic theory based on the work of Sigmund Freud that believes that anxiety initially occurs as a response to a stimulation of birth and need for the infant to adapt and change to the environment. Subsequent anxiety results from intrapsychic conflict. The process of unconscious repression of sexual drive is one of the core of much of the conflict. So again, this is Freud's work. And as we know, Freud is very focused. I'm trying to think how to say it, like very focused on that there's like a sexual component to things. And Freud's work is interesting. So this is not what is shown scientifically. This is what's hypothesized by Freud. So conflicts exist between intrinsic needs of an id and superego, which we'll talk more about. Anxiety signals the person of the need to deal with the id and superego conflict. We're going to talk about conflict is unconscious, but anxiety is consciously perceived. Conflict entails fear of punishment and doing wrong. Defense mechanisms are unconsciously used by the person to deal with the conflict. And the behavior manifestations of anxiety disorder stem from the pathological overuse of defense mechanisms. So again, psychodynamic is Sigmund Freud. Then there is the interpersonal theory. This is by Harry Stack Sullivan, who believed that humans are goal-directed towards attainment of satisfaction and security needs. Satisfaction and the security needs are normally met in interpersonal interactions. Anxiety arises when a person's needs are unmet. Anxiety is first experienced in an infant's interactions with his or her mother, and subsequent anxiety arises because of interpersonal conflict. Conflict occurs when a person perceives his or her needs will not be met because of rejections, feelings of inferiority, an inability to engage with significant others. A sense of self becomes based on the person's perception of how others view him or her. Then there is a neurobiological theory. So pathological levels of anxiety from neurobiological deficits in normal brain function. Deficits are generally mediated by and involve predominantly the limbic system, midline brainstem area, and sections of the cortex. Defects predispose the person to abnormal stress response with hyperactivity of the autonomic nervous system, causing symptoms such as increased heart rate, blood pressure, diaphoresis, pupillary dilation, tremors, and increased respiratory rate. Problems with hypothalamic pituitary adrenal axis. So a threat is perceived and the amygdala signals the hypothalamus to secrete corticotropin release hormone. The amygdala also activates the sympathetic nervous system to start the fight or flight response. The pituitary is stimulated to release adrenocorticohormone. That's a lot of words here. The adrenal glands are then stimulated to release cortisol, which shuts off the alarm system and restores the body to homeostasis. In anxiety disorders, the amygdala may not be able to shut off the response, and there might not be enough cortisol to stop the fight or flight. Neurobiological deficits result in low levels of neurotransmitters, GABA, the chemical response for inhibitory responses of neurons, and high levels of norepinephrine, the chemical responsible for the flight or fight response. And neurotransmitters involved in suppressing the HPA axis are serotonin and GABA. All right, so medical conditions that mimic anxiety disorders. So we can see different disorder categories and what can mimic anxiety. So for cardiovascular diseases, there's a bunch of them: respiratory diseases, endocrine diseases, neurological diseases, metabolic, substance abuse, and dependency. I would say for the exam, a big one to know is hyperthyroidism can look like anxiety or mania. That's an important one to remember. All right, so pharmacological management. So first one is SSRIs. They're most often used first line. The action of serotonin system acts indirectly on the GABA system. It carries no risk of dependency, but can't be used as an as-needed medication because it takes 3 to 4 weeks to start to feel symptom relief. It's generally well tolerated, doesn't have many side effects. Best when combined with psychotherapy, but there is a black box warning on kids that they're more likely, they're an increased risk of harm to themselves, from themselves. So we have to monitor for that. So benzodiazepines, these have a rapid onset of action, so they can be used as a PRN. They work on GABA. We want to limit to the lowest possible dose and short-term use because long-term use can lead to tolerance, dependence, memory impairment, and depression. You should limit the period of excessive symptoms, periods of high stress or remitting symptoms. Use with extreme caution with clients with a history of substance use. The use of benzodiazepines has been associated with Alzheimer's disease, and benzos with a longer half-life require less frequent dosing and have less severe withdrawal and have less rebound anxiety. So benzodiazepines with a longer half-life are more useful for continuous, moderate, and severe anxiety as a bridge medication as we wait for SSRIs to start working. These are things like clonazepam or diazepam. Benzos with a shorter half-life require more often dosing and have more severe withdrawal with rebound anxiety. So alprazolam and lorazepam. And then advantages of benzos with short half-lives is that benzos with short half-lives are often used for remitting and infrequent moderate to severe anxiety, less daytime sedation, less drug accumulation, quick onset of action, and useful for the treatment of insomnia. Disadvantages for benzos with short half-lives is an increased risk of addiction. And you can see the alprazolam, clonazepam, diazepam, lorazepam, and their onset of action versus their half-life and dosing equivalents. So benzodiazepine discontinuation, withdrawal symptoms, and we talk more about this in the substance use lecture, but it's going to vary based on what the half-life is for the medication used. Can be mild, like insomnia, agitation, headache, muscle ache, diaphoresis, tachycardia, to severe, such as seizures, delirium, or coma. Short-acting agents will see withdrawal in 1 to 2 days, but long-acting agents can go up to 10 days. Sometimes if people have been on them for a long time at a high dose, it can be, I've heard of it being months. Rebound anxiety symptoms, hours to days after discontinuation, can be more intense than before discontinuation. Relapse anxiety can be weeks to months after you discontinue it. Then they start getting this relapse of anxiety. A psychological pseudo-withdrawal. This can happen because of a patient's fear of stopping the medication, and tapering the meds provides reassurance that this won't happen. You can also combine it with CBT. Withdrawal management. Most people can taper off slowly. For alprazolam, no faster than 0.25 milligrams per week to avoid delirium and seizures. We want to give patient education, support, and consider substituting equivalent dose of diazepam. So if we reduce diazepam dose by 10 to 20% every 1 to 2 weeks as tolerated. And that's because if we look back here, diazepam is the longer acting benzodiazepine. Has a longer half-life. All right, so then we can also use tricyclics. They're effective, but we don't use them often because they can have more side effects. We don't use them first line because they can have more side effects. And non-benzo anxiolytics, so there is some of them there. Buspar helps for anxiety, but it can take a few weeks for it to start working, so it's not a good PRN. Gabapentin sometimes works for anxiety. It can also be used for like neuropathic pain and fibromyalgia, or as an anti-craving med. And propranolol works really well for performance anxiety and also like trauma-related activation of the nervous system. Lifespan considerations. So we use clonidine in kids. They're very low doses. It's like 0.00 to 0.1 milligrams per kilogram per day. We also use guanfacine as well. Non-pharmacological treatment. So different types of behavioral therapies. We can do things like systemic resuscitation, exposure therapy, relaxation therapy, and biofeedback, cognitive behavioral therapy, interpersonal therapies, community and self-help groups, and alternative therapies as adjunctive treatments. Comorbidities we can see anxiety with. So again, a lot of those medical conditions that we saw at the beginning, like hyperthyroid, right? Also hypoglycemia or Cushing's, some cardiac disorders, pulmonary disorders, and adverse medications, which can also include caffeine. If people drink too much caffeine, they can get anxiety symptoms, mood disorders, and also substance use. So for follow-up, we should see them weekly, bi-weekly. I mean, if you're inpatient, you're going to see them every day. If they're on benzos, we want to monitor for appropriate use and dependence. If they're taking an SSRI, monitoring for side effects, we do that for all meds. Assess for suicidality and depression, and combined medications with therapy. So a good way to measure anxiety is to use a rating scale. And this is good because when a patient first comes to you and they're reporting anxiety and they fill out the scale, you can then repeat the scale and just see, is the medications working? Is the therapy working? And you'll be able to compare. So we're going to go through some of the scales. It's going to kind of give an overview of the scale and then show you what it looks like in the other side of the slide. So Zung's self-rating anxiety scale is a 20-item self-reported scale. We have a whole PowerPoint presentation on the scales that you need to know. So don't get hung up on knowing the ones that aren't mentioned there. So for example, Zung's is not mentioned there. So you really don't need to remember the ranges for this. It's just to kind of show you the different scales that are available to you. Okay, and then that's an example of the scale. Then we have the Hamilton rating scale for anxiety. So this one you will have to know, and it is in that scale slides that we have. So measuring the severity of the patient's anxiety, including anxious mood, tension, fear, somatic complaints. So 14 to 17 is mild anxiety, 18 to 24 is moderate anxiety, and 25 to 30 is severe anxiety. Again, don't get too caught up on this. Refer to the lecture on the scales because I explained to you how to memorize these numbers much easier. But over on the right, you can see that is the Hamilton rating scale for anxiety. Then we have the GAD-7. This is a brief scale for assessing generalized anxiety disorder. And again, there's only 7 questions, very quick. It's right there. And you'll see this in those slides as well and how to remember them. The Yale-Brown obsessive compulsive scale. This is used for OCD, and you can kind of see it over on the right, assessing for different things related to OCD. And this can give you a good idea about the severity of the OCD. I've had patients use this Yale-Brown obsessive compulsive scale, which helped their diagnosis go from a question of possible OCD because they weren't super forthcoming to them actually having moderate OCD. So just very interesting. Panic disorders. So panic disorder is experienced as a discrete episode or attack with a sudden onset of intense fearfulness and terror. They occur without warning in the absence of any real danger. Attacks build to a peak of intensity within a short self-limiting time, usually within 10 minutes. It's more common in women than men. And after the first attack persists, common over having, after the first attack, the person has persistent concerns over future attacks with a significant behavior change related to that attack. So paresthesia, chills, hot flashes, fear or loss of control of going crazy, fear of dying, shortness of breath, palpitations, chest pain, sweating, trembling, nausea, vomiting, diarrhea. People have 4 or more of these, and it happens very quickly, and it peaks at about 10 minutes. Agoraphobia. So this is the avoidance of places or situations from which escape may be difficult or embarrassing, or in which help may not be available. The anxiety usually leads to avoidant behaviors that impairs their ability to travel, work, or carry out responsibilities of living. Specific phobias. Patients will experience a clinically significant high level of distress when presented with an object of their phobia. Stress can occur simply by thinking about the object, for example, heights, snakes, dogs. The patient may be aware that the fear is unreasonable and excessive. Risk factors for the phobia include a past traumatic exposure, for example, a near drowning, then they might be scared of water, or a vicarious trauma. They see a friend drown or nearly drown, and then they get scared of water. Excessively transmitted information. So frequent parental warnings, you will drown if you go in the pool, could lead to fear of drowning. In adults, but not in children, exists the conscious recognition that the fear is excessive or unreasonable. And in children, the degree of insight to unreasonable nature of fear increases as age increases. Risk factors, so traumatic past exposure, observing of another, excessive information transition, and then also genetic loading. Social anxiety disorder. So this is a marked or persistent fear of social or performance situations in which embarrassment may occur. Anxiety levels are often sufficient to fit the criteria for the situational bound panic attack. The disorder has an estimated 3 to 13% prevalence rate among the US, and rates are equal for all genders. So when we are assessing people for anxiety disorders, we want to get a good history. So we want to know the degree of social anxiety. We want to know that some degree of social anxiety is common in teens, and social phobia should be diagnosed only if symptoms persist for longer than 6 months. Onset in the mid-teens, often followed by stressful or humiliating experience, and tends to remit with age. Differential diagnoses can assist by awareness that people with social phobia do not feel better or experience decreased anxiety when accompanied by a trusted companion. They have a hypersensitivity to criticism, negative self-evaluation, sensitivity to rejection, and a low self-esteem. Inferior feelings, lack of assertiveness, protracted anticipatory anxiety may occur days or weeks before the social situation, and levels of subjective distress and impaired functioning can be significant and have associated with thoughts about harming themselves. So this is all history for social anxiety. For people who are anxious, physical findings, we're going to see sweating, tremors, palpitations, muscle tension, diarrhea, and blushing. Pharmacological management, so we went over this, the SSRIs, benzos, and beta blockers. Non-pharmacological management, CBT, exposure therapy, which is helpful with OCD as well, and relaxation therapy. And then generalized anxiety disorder. This is the most common psychiatric illness occurring in 33% of people in the United States. In the United States, lifetime prevalence is 5.7%, twice as common in women than in men. It can develop at any age, but 75% of cases happen before 47. It is characterized by a persistent and consistent excessive worry, apprehension regarding the impeding or perceived distressing situation that is disruptive to daily functioning and lasts for at least 6 months. We can see restlessness, fatigue, irritability, muscle tension, and sleep disturbance. So with generalized anxiety disorder, like we talked about earlier, the theories that are related to this, we have the neurobiological, which we already talked about, structural dysfunctions. So just structural abnormalities can lead to an abnormal stress response. We talked about this as well. We talked about the HPA axis, and inhibitory mechanisms in the amygdala may be ineffective in turning off the fight or flight response and dispose the individual to panic attacks. So then there is also psychodynamic theories. So we remember this is Freud, what we talked about earlier. So this has the idea that long-lasting kind of mental scars occur during sexual development, and that this mental kind of scar keeps the individual from mastering their psychological milestones. So again, going back to Freud, things are always related to a sexual drive. So anxiety stems from a repression of the sexual drive as the individual is unable to resolve the conflict between the id and the superego. Anxiety is manifested as a result of an unconscious fear of punishment for indulging the id. And the individual may use immature and neurotic defense mechanisms to relieve stress, leading to pathological behavior and causing distress in the individual. And then we have the interpersonal theory. This is by Henry Sullivan. We also talked about this. And the cognitive behavioral theory, which is premised on the interplay of cognitions, emotions, and behaviors driving treatment and is aimed at altering cognitions and thereby affecting emotions and behaviors. Anxiety is thought to be the learned response to which an individual may utilize avoidance to alleviate distress. So when we come to generalized anxiety disorder, this is the DSM This actually says 4, but this is the DSM criteria. And we went over some of those physical findings as well. And when we screen for generalized anxiety disorder, this is the GAD-7. This is a prettier one than we saw earlier. This is the severity measure for panic disorder in adults. Again, you don't need to memorize this, but just some of the tools you can use when you're in practice. All right, so we talked about that pharmacological management. We have those SSRIs, we have the benzodiazepines, we have the tricyclics, beta blockers, gabapentin, buspirone, and alpha blockers. All right, and here is a nice algorithm of all those things that we talked about when treating generalized anxiety disorder. And here are some more pictures about the treatment for generalized anxiety disorder. And here are some botanical medications that can be used for generalized anxiety disorder. You just want to be careful because they can also interact with psychotropic medications, but just, nice to know that they exist. For example, chamomile, ashwagandha, lavender, valerian, all of those can help. You have to be careful with St. John's wort because that can cause serotonin syndrome if they're taking an SSRI. Kava also can help with anxiety. However, it can be hepatotoxic. So you have to be careful with that as well. All right. So non-pharmacological treatment. So we have cognitive behavioral therapy, bibliotherapy, supportive therapy, and then complementary and alternative therapies. All of those can be used as well. All right. So when we communicate with people who have generalized anxiety disorder, we want to avoid giving commands and instead explore steps with the patient. So for example, don't oversimplify. Don't say things like, try not to worry about that anymore, right? That's not going to work. Instead, we want to help the patient to see when a worry can actually lead to a solution. So think of these worries. What do you have control over? What can you do next? Don't push. So don't say things like you need to learn to relax for at least some of the day. Instead, show a mind-body skill after gaining permission. So several times a day, I want you to spend a minute to take 3 breaths. And for each breath, I want you to breathe in for a count of 3, hold it for a count of 3, and exhale for 3. So just some nice tools that you can use. So don't assume. So your stress is so high, I want you to get others to help you more. Instead, explore possibilities. Like at times like this, support can be helpful. Who has helped you before? Don't invalidate. I know you have a hard time believing these symptoms are connected to anxiety, but I need you to try some of these changes. Instead, use an example analogy. So have you ever seen someone start sweating when they're nervous? The feeling leads to changes in the body. Would you be willing to practice one of these behaviors to help calm you down? And then reference a handout. Coping strategies to teach the patient so we can help them to practice relaxation skills, make a list of things they worry about in the evening before bed and give permission to address them tomorrow. Enlist or accept emotional support from others, reduce caffeine, adopt good sleep hygiene, and use a digital application to help promote self-help. So separation anxiety disorder, this is characterized by a developmentally inappropriate excessive apprehension and worry related to separation from their attachment figure or source of comfort. Developmentally inappropriate and excessive distress occurs after the age of 4 when faced with separation from a major attachment figure and can extend into adulthood. Then we have obsessive compulsive disorder. So this is characterized by recurrent thought, urges, and images and experience it as intrusive and unwanted that the patient attempts to ignore or suppress and or repetitive behaviors or mental acts that the person is compelled to perform in response to the thoughts according to rules that must rigidly be applied for the purpose of reducing the individual's subjective anxiety level. So an obsession is a recurrent or persistent thought, impulse, or image that is experienced and causes anxiety or distress. Experience it as intrusive and inappropriate. They're ego dystonic. So remember, we talked about this before. So it's something that the person feels upset about. It doesn't resonate with them. Thoughts of contamination, dirt or germs, persistent doubts such as having hit somebody or hurt somebody, the drive to have things organized in a very specific way, aggressive or horrific thoughts, persistent sexual imagery, obsessions are not usually grounded in reality. Patients recognize that the thoughts and impulse are products of their mind only. They spend a considerable amount of time trying to suppress them. and they may exhibit avoidant behaviors. Compulsions are repetitive behaviors or mental action the person feels driven to perform in response to the obsession, such as hand washing, cleaning, checking lights, burners or locks, persistent organizing and reorganizing, counting, silently repeating words, prayers. Patients may attach superstitious meaning or magical thinking to behaviors or thoughts. Then there's something called PANDAS. This is a pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections, and it should be considered when acute onset signs and symptoms arise in children because it can lead to OCD or OCD symptoms. So treatment is usually SSRIs at very high doses. There's also some TCAs, and second generation antipsychotics such as risperidone are off-label, but have data supporting their adjunctive use with SSRI medication. CBT and exposure therapy are non-pharmacological management. And then post-traumatic stress disorders. This disorder that occurs after witnessing a traumatic event. The event is one that represents a threat to life, limb, or specifically defined as actual or threatened death, serious injury, or sexual violence. Exposure to the event can include directly experiencing that event, witnessing the trauma to others, indirect exposure via violence or accidental trauma experienced by a close family member or close friend, and repeated or extreme exposure to aversive detail of a trauma, such as a first responder collecting human remains or law enforcement officers being repeatedly exposed to horrific details of child abuse. There are 4 categories of symptoms for PTSD. That's intrusion, avoidance, negative cognition or moods, hyperarousal, or reactivity. So those who commonly experience trauma, there's a list of different types of trauma there. The duration of symptoms, if it's an acute, so post-traumatic stress disorder acute is when the duration of symptoms is less than 3 months. Chronic, it's longer than 3 months. Delayed onset, at least 6 months between the traumatic event and the onset of symptoms. And first-degree relatives of those who have PTSD are at a higher risk. When we assess for PTSD, the gold standard is the clinician-administered PTSD scale for DSM. This was created by, I believe, the Veterans Association. It is a 30-item questionnaire. Full interview can take 45 minutes to an hour to complete. And scores are 0 is absent, 1 mild, 2 moderate, 3 severe, and 4 extreme. Sample questions include in the past month, have you had unwanted memories of an event while you were awake? So not counting dreams. How does it happen when you start remembering? Are there unwanted memories you were thinking about on purpose? How much do these memories bother you? Are you able to put them out of your mind or think about something else? How often have these memories happened in the past? So when we talk about symptoms, so characterized by symptoms of increased arousal and avoidance of stimulus associated with trauma persisting for 1 month or longer. Re-experiencing symptoms, so they need to have one or more of the following: recurrent and intrusive thoughts or recollection of the event, flashbacks, dissociative states lasting hours or days, nightmares regarding the event, intense distress at exposure to cues in symbolizing the event, physiological reaction upon exposure to cues symbolizing the event. Avoidance symptoms, they should have 3 or more of the following, so persistent avoidance of stimulus associated with the event, effort extended to avoid talking about the event, inability to recall aspects of the event, significant anhedonia, persistent feelings of detachment or estrangement from others, restrictive range of affect, impeding sense of foreboding or shortening future or premature death. Persistent hyperarousal symptoms, 2 or more of the following, so difficulty falling asleep, irritability or anger outbursts, difficulty concentrating, hypervigilance, or exaggerated startle responses. In a physical exam, we'll see increased rates of somatic complaints, insomnia, distractibility, and tachycardia, diaphoresis, increased respiratory rate, papillary dilation, and increased startle response. And that's because they have an increase in autonomic symptoms. So here is the full DSM-5 criteria for PTSD. I'm not going to read it all out loud, but you can pause this and look at it if you would like. So how do we assess for DSM-5 criteria for PTSD? So if there has to be a traumatic event, then there has to be a traumatic exposure. They have to meet the symptom criteria. So 1 intrusion, 1 avoidance, 2 cognition, 2 arousal, duration for more than a month, and distress or impairment, and that will give you a diagnosis of PTSD. There's different treatments that we can use. So psychological intervention, we have all those different types of therapies. EMDR is like the gold standard for therapy for PTSD, hypnosis. And then for pharmacological treatments, there's a bunch of different ones that we can use as well. So SSRIs, they often need higher doses, TCAs, benzodiazepines, antipsychotics, for flashbacks. Alpha antagonists may be used for treating nightmares. So prazosin we use a lot for nightmares. And here are first and second line treatments for OCD. So there you can see the first line agents, the dosing, adverse effects, and concerns that we can see with those. So non-pharmacological management, a bunch of different types of therapy, and that eye movement desensitization and reprocessing. So that's important to know for the exam. Like we talked about in other lectures, you want to look at the key differences. So EMDR is specifically used for PTSD, right? Where something like CBT is used for a ton of disorders. So you'll probably be asked, like, what is the treatment, non-pharmacological treatment modality only used for PTSD or something, right? So EMDR goes with PTSD. If you've ever seen EMDR, it's like they hold this little like wand looking thing and they wave it in front of the patient's face and it makes their eyes move in a certain direction, which like reprograms some of the trauma. They think about the trauma as they do it. It's very interesting. So pretty cool. Then we have adjustment disorder. So when you remember that time, that like algorithm of how you diagnose PTSD, sometimes people don't fit all of the things, but they still are having symptoms of it. And that's where you would diagnose adjustment disorder. Then we have dissociative disorder. So these are characterized by inability to recall information, autobiographical information, usually in response to a traumatic exposure in which the person experiences depersonalization, derealization, and dissociation. Dissociation is a defense mechanism that protects a person from overwhelming anxiety by emotionally separating. Depersonalization and derealization is a persistent feeling of onset not being real or the environment is not real, but reality testing remains intact. Derealization is an alteration in the perception of the external world, so it seems unreal. And depersonalization is when the person feels detached from their self. It can be physical or psychological. Physical causes are seizure, migraine headaches, psychedelic drugs, and alcohol. And psychological causes are severe anxiety and traumatic stress. So dissociative identity disorder is characterized by two or more distinct personalities. This used to be called multiple personality disorder, but they changed the name. Personality states are generally split off from one another, leading to a gap in a recall of everyday events. Symptoms cause significant distress in functioning. It can be comorbid with PTSD. It's usually due to a history of severe physical or sexual trauma, or both, usually in childhood, which causes the personality to kind of separate into distinct personalities. Body dysmorphic disorder. So this is characterized by a preoccupation with the perceived deficits or flaws of the physical appearance, in which the individual engages in repetitive behaviors such as mirror checking or reassurance seeking. Preoccupation with one or more of perceived deficits or flaws in physical appearance, engages in repetitive behaviors in response to appearance concerns. Preoccupation causes considerable distress. Insight ranges from good to poor to absent. And males typically suffer from an Adonis complex in which they perceive their muscles to be inadequate. Hoarding disorder is a persistent difficulty disregarding possessions regardless of actual value. Experiences mark distress in response to pressure to discard. Results in accumulation of possessions that compromise living space and ability to function or maintain safety in their environment. And insight ranges from good to absent. In trichotillomania, this is where someone pulls out their hair, causing significant significant stress. The hair pulling is not an attempt at correcting an imperfection or improving one's appearance, as in grooming. And they cannot stop, and it's not an attempt to improve a deficit or flaw. Excoriation disorder, this is skin picking, which results in lesions despite attempts to stop. Oh, and that is the end. So I will see you guys in the next one. Bye.